our SADA webinars. This month, we're actually commemorating the Youth Month. As we all know, that the month of June is our Youth Month. Tomorrow we'll be celebrating Youth Day. I'm fortunate to still say I'm still part of the youth. Before I introduce our speaker for tonight, SADA is actually embarking on a mentorship program directed towards the younger colleagues. And we do understand that younger colleagues know the importance of mentorship and the actual having of mentor to guide them along the treacherous and difficult waters of dentistry. So we request those mature colleagues who wish to participate in this program to please complete a poll, which we will bring up in the latter course of tonight's webinar, if you are interested to be part of this initiative. Now, tonight's webinar is being discussed or actually presented by an individual I think we all know and requires no form of introduction. Unless you have not been in the dental world, you should all know about Dr. McKelvie. But for the few of you guys, the rare few that do not know about Dr. McKelvie is a dentist that has been with dental protection since the year 2000. And he now is also the head of dental services for South Africa. He hails from the UK, but in all honesty, I think Alasdair is very much South African. And therefore, I actually would not like to say Alasdair is from the UK, but he's a born again South African. So I would like to welcome everyone to tonight's webinar, and our speaker for tonight, Dr. Alasdair McKelvie, who will be discussing a topic, defensive dentistry. Does it really reduce your risk? Alasdair, the floor is yours.
Okay, thank you, Sadir. Are you going to do some house rules before I get started?
So, Alasdair, because you are so special to the dental world, we have actually brought in a co-host tonight to just bring down a few rules and regulations, in essence of a dental protection webinar. So I'd like to introduce you all guys to Dr. Avi Ramdil, who's also a member of our YDC. Dr. Ramdil, can you please pave the road out for our rules and regulations for tonight? So Alasdair, make start.
Okay, hi, good evening, colleagues, and welcome to another webinar. So there's just a few house rules to go through. Kindly refrain from using the raised hand feature. You may type your comments and questions in the Q&A tab. The CPD certificates will be loaded to the SADA platform, and you'll be able to access all your certificates under your member profile. If you're not a SADA member, you'll be able to create a profile for yourself and access your CPD certificates. The event for tonight qualifies for 1 clinical CEU. If you're experiencing difficulty accessing the Zoom platform, we are also streaming live on YouTube. Thank you. That's just the house rule. So we'll go through the questions towards the end, but everyone can send through the questions in the Q&A tab.
Thank you, Dr. Ramdil. Now that we know about the T's and C's for tonight's webinar, and guys, as much as the webinar just carries 1 CPD point, I think what we're going to take home from this webinar will also honestly be priceless. So Alasdair, the floor is yours.
Okay, thank you very much. I'm presuming you are seeing my full presentation slide.
Yes, Alasdair, we can. It can be clearly seen.
Brilliant. Okay, thank you for the introduction. Defensive practice, does it really lower your risk? This is the first time I put together a talk for any dental professional group in South Africa or anywhere in the world, actually, on the topic of defensive dentistry. And if we think about medicine, defensive practice in medicine is probably best understood in its simplest form as unnecessary investigations undertaken by a medical practitioner to protect them from the risk of litigation. So the idea is that you test, investigate, overload, and in many cases expose the patient to additional costs, more radiation, and more interventional investigation to limit the reliance on human diagnostics. So it's the kind of gut feeling, pattern recognition and heuristics that we have, the I know what it is because I've seen that before type of approach to clinical problem solving. Now, heuristics and anchoring on recent experiences in dentistry is an interesting concept. And it reminds me of a situation I was confronted with during my oral surgery, oral medicine, Viva, in my final year exams at dental school. And this was a long time ago, but the idea was that the exam included the evaluation and diagnosis of a patient with a common oral surgical or oral medicine condition. And there were obviously a number of patients who could be allocated at random. Anyway, I'm sitting in the coffee bar of the dental school waiting for my turn, and one of my friends has just completed his Viva, and he tells us he thinks he's just seen a patient in the exam with benign mucous membrane pemphigus. And I've got no idea what it is now, but we all said, don't be stupid. There's no way they would put something as complex as that in the oral medicine spot exam. Well, as it turned out, I go up and I find myself looking at the same patient, pattern recognition, and I'm in and out in a couple of minutes with a good pass. For me, that's pattern recognition, heuristics, and just damn good luck. So there probably isn't an obvious definition for defensive dentistry, because I suspect the concept of defensive dentistry is not just about limiting exposure to risk and complaints about our clinical competence, but it also includes self-serving actions which are designed to reduce financial risk, reputational risk, that sort of thing. So what is defensive dentistry? Well, it's probably all of these factors acting either alone or in combination that sort of drive fear avoidance, defensive behaviors in dentists. So we're actually limited or constrained in dentistry by the fact that we rely less on diagnostic tools, investigations, bloods, and rely more on what we see with our eyes, what we feel with our probe, and what the patient tells us when we ask them what's wrong. Maybe as the number of CBCT scanners grow in practices, we can predict there'll be perverse incentives as well as the fear of driving the number of scans taken. But we're not yet picking up complaints where the investigation was deemed unnecessary and overtly defensive by a well-informed patient. So let's have a look at some of these avoiding treatments that you're less confident providing. So the first example I'm going to talk about, and you're one of these guys who don't like doing complex multi-root endodontics, where there might be 4 root canals in tooth 16 here. It's this upper right for a smaller tooth. And this patient walks in with an irreversible, very painful tooth. It's been keeping the patient awake for 2 nights, and it's all been very distressing. You're pretty handy with the forceps, and the patient is booked in just before lunchtime. It's been a busy morning and everybody wants to stop for a breather and to have some lunch, but you know you've still got to treat this patient first. The patient is told there are 2 options and agrees to the extraction. The tooth's removed without any issues and the patient goes home. The loss of the tooth begins to trouble her after the local anaesthetic's gone, and it had never occurred to her that the solution would involve removing the tooth. At decision making, she was given both options, but because the dentist was worried about doing a complex restorative job, then he was more comfortable carrying that out, and this is what the patient agreed to. So when the patient made her complaint, she reported that her choices were root canal treatment described as 2 45-minute appointments, which was not pleasant, or an extraction which would be over in 5 minutes. Now, if you're the patient, you're probably going to think, well, I've been in pain for 2 days. This is really distressing me. I'm going to go for the easy option, which is the extraction. And then she says in her complaint that she felt pushed into a quick decision, and I was not expecting this outcome when I went for the appointment. It was a big decision, even the nurse said so. And the nurse had even suggested she could go home with painkillers to think about her decision. But really, the last thing they wanted was for the patient to choose endodontics. So that's what she said. I now have a huge gap. I'm distressed about it. In fact, I am gutted. So defensive dentistry ends up with you carrying out a procedure you're more comfortable with. You avoid the high-risk endodontic procedure and you end up with a complaint. Could this case have been managed any differently? Well, as a general rule of thumb, not everybody is equal in the clinical competency table. And I was never great at surgical dentistry, especially early on in my career. and I would avoid the extraction and attempt the endo any day, and the patient seemed to benefit until we couldn't restore the tooth-eyed root filled. So they would have been much better off with the extraction in the first place. But if the information you give the patient is presented in a self-serving way, then it can lead to wrong outcomes. You favour the procedure more comfortable with to avoid the problem, and you end up with the very thing you were trying to avoid in the first place. So that's Sod's Law. Let's have a look at another case here. And in this case, more often than not, this extraction ought to be within the skill set of the average reasonable practitioner. What happens if you refer this patient to a specialist rather than another colleague because you don't like undertaking surgical extractions to avoid something going wrong for you? Well, what happens if it turns out to be just a flick out with a luxator for the max fax, something that was so simple you could have done it, yet the patient has to pay the max fax fees rather than the generalist fees? Is this a fair outcome? Well, some people may say yes because the risk has been avoided, but others may disagree. Now, we had a case last year where the examining dentist referred a patient needing a lower molar extraction to another colleague in the same practice on the basis that the extraction could be problematic. The extracting dentist never examined or discussed the option of conscious sedation with the patient, but made this unilateral decision that the patient needed to have conscious sedation provided with the extraction. So the patient was told, not by the dentist, but by the receptionist, that she would need to contact the anaesthetist to find out what the treatment cost would be. And there then ensued a disagreement between the patient and the anaesthetist receptionist about getting discount on the anaesthetist fees. And it got to the point where the anaesthetist said, look, I'm not taking any more of your bad mouthing and bad language and your discontent, and I'm just not going to go ahead and do the procedure. Well, that message got back to the extracting dentist, and he contacted the patient and said, look, the anaesthetist is not happy to do the procedure, and nor are we. I'm afraid you're going to have to go somewhere else. So the patient ends up having to go somewhere else, and lo and behold, guess what happens? The tooth's extracted with local anaesthetic and for a quarter of the price, and that generates the complaint. And we had a very difficult job convincing the patient that there was an error here, and that her proposal or suggestion that there was a sharp practice going on and that they were over-servicing patients wasn't true. But it was just down to the fact that there hadn't been a face-to-face discussion with the patient, and that's what generated the problem. So then in this case, you have another extraction that you avoid doing the endo because the patient's been really difficult about costs and guarantees. So you opt for the easiest and cheapest option of the extraction, and then you end up pushing the root into the antrum because you don't lift the flap, you don't remove bone, and you just rely on a luxator approach to avoid the additional costs of surgery. It's a self-fulfilling defensive dentistry prophecy, and it ends with a complaint. No thanks for trying to save the patient money, just recrimination. And there we go, there is the complaint. Dr. M billed me for 4,300 Rand. Your practice must compensate me for this unplanned amount I had to pay out of my own pocket. I was put in an untenable position without any choice but to see this surgeon on urgent basis without any due diligence on my part. And all of this was because you did not do your job properly. So the dentist tries to cut corners, tries to do things as cheaply as possible, and ends up creating the problem that they're actually trying to avoid. It's another form of defensive dentistry. So let's look at another case, and this is more about fear of losing face. And it arises from this whole business of feedback and patients carrying out Google reviews, and it actually works both ways. And it's great when somebody publicly thanks us for providing a great service and then tells the world before we buy any services these days, we have an opportunity to see how well other people view our services. We do it when we're making decisions about going on holiday, where we stay, about restaurants, about wine farms, even distilleries in Scotland, all sorts of things we look at. And our patients do exactly the same when they're looking for a dentist. They look at the Google reviews to see who's got the Google reviews, and they quite often make decisions based around that. So as I mentioned, it's great when it works positively, but sometimes it brings out our defensive behaviors when we feel review misrepresents the facts. So if we have a look at this, we've got a patient giving the dentist 1 star. I was quoted 4,000 Rand to fix a broken cap. I'd advised that I needed to do root treatments. I agreed. 6 visits later, I have a bill of 17,000 and the broken cap is still not fixed. When I complained, his response was, but you're making money during COVID? Imagine the audacity. Well, you're making money out of COVID. Why shouldn't I make money during COVID? Now, the problem this dentist did was that he's just committed one of the biggest ethical breaches by breaching confidentiality, by discussing the patient's dental treatment in a public forum without her permission. And I think this is understandable, but you've got to avoid this. And just because the patient talks about their care in a public forum doesn't overwrite her right to confidentiality from her dentist. Now, with the full implementation of POPI, the response from the dentist in this defence amounts to the illegal processing of the patient's personal data. There is no consent for this disclosure either, so we're looking at a number of potential problems. We're looking at a potential claim for damages flowing from the breach of confidentiality. We're looking at an HPCSA investigation into the ethical breach of confidentiality. And then we're looking at a possible fine following the POPI breach for processing the data in a way it was not collected for. So while as tempting as this is something that you must avoid doing on social media. And the best way to respond to negative criticism is to say, I'm sorry you feel like that. Would you like to contact the practice where we can discuss it in private? And that's really the best way. And if you don't know who the patient is, or you believe the patient's mischievous and not a patient of the practice, you just say, we don't recognize you as a patient of the practice. Again, if you want to discuss this further, please contact the practice. But please don't get into the defensive habit of trying to defend your reputation by actually pointing out the inaccuracies in the review posted by the individual patient. So this is the key ethical guidance, and it's HPCSA book at 16. It talks about trust being central to the relationship, and you need to make sure you familiarised yourself with the content and the key rules. And it doesn't take long to bump into 6.1 and 6.2. 6.1 speaks to the constitutional right to privacy and confidentiality. And then 6.2 confirms the rules limiting disclosure of patient information to circumstances where there's a court order for the patient, or where the patient has agreed you can disclose confidential information, or whether it is lawful for you to do so. So let's look at some of the problems around defensive dentistry that are driven by the fear of losing money. So it's not surprising the HPCSA and the SADA mediator find themselves frequently trying to resolve a situation where the patient has refused to pay an account for services rendered, but not necessarily agreed to because they weren't told in Rand what the service would cost. And the dentist says, this is not fair because I've got a document here in my possession that the patient has signed saying they will be responsible for paying all charged services. It's always a good idea to make sure the patients fully understand the house rules and that they accurately represent the legal and ethical framework we all work with. In the slide here, I've reproduced 3 house rules frequently seen. 1 is wrong. Now, number 1, you're responsible for paying your own fees and all accounts must be paid in full before leaving the surgery. I have no issue with that. Number 2, all accounts still outstanding at 60 days will be handed over for collection without further notice, and the cost will be for your account. I have no issue with that. However, I'll come back to dealing with bad debts in a minute. And the 3rd one, which is the wrong one, it's the patient's responsibility to inquire about costs. Unfortunately, that is not the case. And if you are reported to the HPCSA where the complaint is, I wasn't told about the costs of my treatment, then they will quote Section 6 of the National Health Act and Ethical Rule 27 AD. The Act says that every dentist must inform their patient of the costs associated with each option. And then the Ethical Rule 27 says at all times provide adequate information about diagnosis, treatment options, and alternatives, and costs associated with each such alternative. Now, if I'm going to be slightly pedantic, that seems to be saying costs associated with each alternative rather than the main option. But I wouldn't like to have an argument with the HPCSA over whether this rule is written correctly. I think it is, and I think they're very clear about what they mean here, that this applies to giving the patient the cost of the main option from the diagnosis and all relevant costs of all the other options. Now, I saw a poll that appeared on my screen, and presuming you're being asked to answer that poll, so that's fine. So let's talk about fear of being sued and the defensive steps we can take and sometimes get wrong. And I want to talk about consent forms because they are overrated and they're actually counter-defensive unless crafted specifically for each procedure. So if you ever think about any consent form or terms and conditions you've been asked to sign, most of us don't read the document. And it's the same for our patients. We give them a consent form to sign as a matter of policy. And historically, we've used consent forms to protect the doctor from an illegal assault or battery charge. And the consent form was developed from the days of Bolam, where paternalism ruled and doctor knew best. The modern consent form, if it provides the defense it is meant to provide for, must follow the discussion and the conversation that takes place in the surgery. It is no use if the consent form talks about generic risks. It has to be tailored to each patient's specific clinical situation. The law in South Africa actually only requires the discussion to take place. There's no law that requires you to provide the patient with written material. So the recording and the provision of a consent form is not mandatory. The recording is not recording the actual conversation. Recording means writing a note in your treatment record. So the conversation is the key. So if you want my advice on consent, then listen carefully. First of all, examine the patient to find out what they want or what the problem is. Gather together all the information you need, including models and x-rays. Once you've got all of that information, that should help you make a diagnosis. Once you've got a diagnosis, you can identify the treatment options and then discuss them with your patient. So you then discuss the treatment options and the cost so the patient can make an informed decision, an informed choice. Write down the key discussion points in your treatment notes. If there is a decision or a choice to be made, give the patient time to go away and think about their options. When they ask you for your recommendation, don't say to them, I can't influence your choice, it's all up to you, because that's defensive again. Tell them what option you would choose if you were faced with that situation, or which option that you would recommend. If the diagnosis and treatment is complex, or if it's elective, then set it all out in a letter to the patient. That letter probably becomes your consent form, because if the patient writes back to you or confirms, yes, please go ahead with what you've asked me to consider, you can do so without needing a signature on a consent form. So the third topic I want to briefly mention here is the disclaimer. And during the pandemic, and particularly when people were returning to work, some of you will have asked your patients to sign a disclaimer to protect you from perhaps from an allegation or a claim that a patient caught COVID during a visit to your practice. You know, at first flight, it's maybe not a bad thing to have done. And we see disclaimers everywhere. The reality is that the disclaimer is not watertight for the following reasons. So the first thing is a patient cannot consent to negligence and is likely to be told by their attorney that the disclaimer is not enforceable in the event that your infection control protocols and use of PPE fell below the reasonable standard of care required of you during the pandemic. So the patient can't agree to you providing a negligent standard of treatment. You also cannot contract your way out of a common law duty of care, as the duty of care is absolute. And then requiring a patient to sign a disclaimer precluding them for suing you for damages would probably constitute unprofessional or unethical conduct before the HPCSA, as this disclaimer seeks to place your interests ahead of those of your patient. So the disclaimer would undermine those ethical principles of non-maleficence and beneficence, and given the power imbalance in the relationship between you and the patient, it might also be regarded as an abuse of your position. The downside of the disclaimer, we believe, is it actually plants the seeds of doubt in the patient's mind that the very place they caught COVID was your dental practice. If there are any concerns from patients, you just need to explain that dental practices have always had to comply with strict standards of infection control. And you can probably explain all the additional steps you've taken to make the environment even safer. I think the disclaimer just draws attention to the fact that you're feeling guilty about something and you've got something to hide. So even though you feel like it's defensive and it's a form of defense, it's not something that we would recommend. And the final thing I want to do is talk very briefly about the words without prejudice, because I see lots of dentists writing to their patients who've made a complaint and putting the words without prejudice at the top of the letter. Without prejudice is used in legal disputes between two parties where the one is claiming something from the other. It's only supposed to be used where a settlement is contemplated. So without prejudice communications between parties are privileged and are therefore not discovered, not used as evidence in a court case. And the idea is that both sides, the litigants and the defense, are encouraged to have open discussions to resolve matters amicably. And if litigants were afraid that every communication they made would be disclosed in court one day, this might prevent parties from genuinely trying to resolve a dispute. So without prejudice communications, as I say, are privileged. And what has happened over time is that attorneys and their friends tend to think that simply slapping the words without prejudice on a letterhead protects that communication from scrutiny further down the line. It doesn't. In fact, if the contents of a letter are clear that the letter's intention is to try to resolve the dispute, i.e. settle it, then there's actually no need to put those words without prejudice on the letter at all. So if you like using the words without prejudice, there's no need to. It doesn't give you that extra ring of defense. So let's look at how the disclaimer doesn't work in clinical practice. And this patient with the mouth you can see in the pan sees dentist A. There's no pain, but there's a massive cavity in tooth 37 on the mesial surface of it. So if you all have a good look at that, you can see that massive mesial cavity. But dentist A knows the patient is going to be back within an emergency, so he does a filling in this tooth. You can see the filling there on the left-hand side of the screen, and understandably the filling was really difficult to put in, difficult to get a matrix band round there, difficult to actually get your burr or get a burr long enough to get into the cavity. But understandably, this filling leads to pain, and dentist A advises the patient that they must have the extraction. Patient doesn't want the extraction, so the patient goes to dentist B and has a root canal treatment carried out because he doesn't want his tooth removed. Dentist B does the root filling, but asks the patient to sign a disclaimer saying he's done the root filling, but he cannot be responsible for the reintegration of the tooth into function. Dentist B correctly identified the need for root filling, but failed to advise the patient that the restoration of tooth 37 after the root treatment was complex and would require attention to all of the teeth in that bottom left-hand quadrant. You can see there that you cannot restore 3.7. You need to re-restore 3.8. You probably need to re-restore the implant that we would say is placed at 3.5. So trying to be defensive, using a disclaimer, dentist B ends up with a patient who wasn't given sufficient information about the costs of restoring 3.7 and chose to end the complaint by providing a refund. The disclaimer was absolutely no use. This example actually raises a wider point about patients shopping around for individual items of treatment on their terms. And we're seeing more and more cases where individual items of treatment are provided by dentists without looking at the overall needs of the patient. So your training requires you to make a proper diagnosis of the entire oral health system in all non-emergency systems. So please don't fall into the trap of providing single items of treatment in the absence of a proper diagnosis. Just because the patient says they cannot afford anything more, it's amazing how many of those patients subsequently, when they've got something to complain about, find the money to pay for their attorney to try and sue you. So let's now talk about difficult patients and difficult conversations with those patients with some clinical examples. And before we do, I'm kind of very conscious that we need to be aware of two ethical rules which can drive our defensive behaviour around those difficult conversations with our patients. So the first is about supersession, and patients move around nowadays. They don't necessarily stay with you for 10 or 15 years. They go on holiday, they look for deals. Sometimes they're away from you in the middle of a treatment, or at the end they seek assistance from a different colleague when they have a problem. And it may not be an emergency in the true sense of the word, and it's often not possible to comply with either of the conditions under Ethical Rule 10 on supersession. And if we look at what Ethical Rule 10 says, a practitioner shall not supersede or take over a patient from another practitioner if he or she is aware that such patient is in active treatment of another practitioner, unless he or she, A, takes reasonable steps to inform the other practitioner that he or she has taken over the patient at such patient's request, and B, establishes from the other practitioner what treatment such patient previously received, especially what medication, if any, was prescribed to such patient. So what Ethical Rule 10 is saying is there are lots of circumstances where before you do something to somebody else's patient, where they're probably still under treatment, you need to take reasonable steps to inform the original treating dentist, maybe even if the patient hasn't requested you to do so. And then you've got to establish from the other practitioner what treatment is currently underway. Now, we just don't have time to do all of that, and it's unreasonable to do so. But sometimes we unwittingly rely on Supersession Rule 10 to avoid providing treatment to patients. And I'm going to give you a clinical example in a minute. The second rule, ethical rule that we need to be aware of that can drive defensive behaviour is Ethical Rule 12, which talks to a practitioner shall not cast reflections on the probity, professional reputation, or skill of another person registered under the Act or any other health act. Now, what this is saying is that if you see something dreadful in a patient's mouth that you know has been completed by a dentist, you're not actually able to comment constructively in what you are seeing if it implies some criticism of a dentist who's carried out this treatment. So seeing other people's denture problems obviously carries a lot of risk to it. And a lot of dentists are ultra cautious about becoming involved, even in carrying out an ease on somebody else's dental treatment, especially simple adjustments to overextended phalanges, where there's a sore spot or an occlusal imbalance. And it's understandable, because what happens if the patient says that that adjustment you carried out actually damaged their denture? We would probably try to avoid carrying out adjustments and say to the patient, look, leave your denture out, let the sore spot heal, and then go back to see the dentist who crafted the dentures and ask that dentist to adjust them. Well, you think that's fairly reasonable behaviour, but to the patient who owned those dentures, it's not. And the patient complained, and this is what the patient said. I came to see you to ask if there was anything you could do with my new dentures, which were causing me a great deal of pain and had caused large ulcers in my mouth. I came to the area to visit family. I hadn't seen them for over a year because of the pandemic. And for some reason, you seemed unwilling to do anything, although I'm sure why. As you said, it was a long time since you'd seen such a large ulcer. I ended up having to leave the dentures out, which was very upsetting, embarrassing, as my family didn't know I had false teeth. So sometimes it matters to patients that you don't offer them some emergency treatment. And here's the chrome cobalt denture where the patient comes to see you. They've just had this chrome denture fitted. Your colleague's away on holiday and they say to you, my upper denture is so tight, I can't get it out. And you've got that dilemma. Do you actually get the orthodontic pliers out and bend the clasp just to relieve the pressure in the tooth? Because we know there is a number of times that we've attacked chrome dentures and we've actually broken the clasp, and you know you can't repair those. You're back to having to make the patient a new denture when none of it was your fault. So you tend to avoid, you tend to take a defensive approach and avoid trying to carry out the adjustments. And of course, sometimes this leads to another complaint. I came back to the practice as the upper denture fitted by Dr. X was so tight, I could not get it out of my mouth. I came to see you as Dr. X was away on holiday. You made a small adjustment to the denture itself, but did not touch the clips. As you said, you didn't want to take the risk they would snap off. I had to go to hospital over the weekend as my teeth got trapped between the back clip and the tooth, and I could not get it free despite the pain I was in and the amount of bleeding. So this patient was obviously unhappy and couldn't understand the justification for the defensive dentistry. And then you get the second opinion, the patient that comes to you for a second opinion. I'd like a second opinion. The lower denture made by the dentist down the road doesn't fit. Can you tell me why? And you say, well, you know, you're saying to yourself, I don't want to get involved in this. And I don't want to be seen making disparaging remarks about another dentist or colleague. You must go back and see the colleague yourself and try and get the solution that you're looking for. And of course, this dentist then gets a complaint along the lines of, I paid you for a second opinion as to why my lower denture was loose. You said you did not know that I should take this up with the dentist who made the dentures. I've since learned that it was perfectly obvious why they were loose, and seemingly for reasons of your own, you chose not to tell me. I feel very deceived having paid your consultation fee and have already spoken with the HPCSA. So defensive dentistry, probably for all the right reasons, and you end up getting the thing that you were trying to avoid. And then you get this case where a new patient walks in who's been with the same dentist for 20 odd years, and you take some x-rays and you realize that there's fairly advanced attachment loss and periodontal disease. And the patient said, I love my previous dentist. They took really good care of my teeth for 25 years. They said getting loose teeth was just part of getting old. Would you agree? Well, no, that's not what you're seeing from your clinical records and radiographs. And you're going to have a conversation here about why getting old and getting loose teeth is not something that happens. It's actually something that can be avoidable. And that creates a difficult conversation that makes people very defensive. And then you get other adjustments. You get the patient coming to see you in pain after a restoration is placed by another dentist, and you're desperate that you want it to be a high spot. So you go and find one and hope that the pulpitis goes away because it protects you and the dentist who placed the filling, but who's not available to fix it. And the truth is, we see a lot of examples of conservative, defensive emergency pain management where it's brutally obvious the patient needs a pulpectomy or something involving the pulp. And the symptoms and the history nailed the diagnosis, but the patient wanders off with his prescription for pain meds and antibiotics. And we know the patient's own dentist will be back in 2 days, so let it be their problem to solve. We know if the patient phones back tomorrow and says, look, I'm still in pain, you can always say to them, look, I don't think you've given the antibiotics long enough to work. And, you know, that's another form of defensive dentistry. We're just trying to get out of doing something irreversible that we could then get the blame for. And it's natural. It's a natural thing to feel. And then in the roadshow talk last month, I mentioned 2 cases involving antibiotics. And, you know, there are limitations around when antibiotics are being used, but I've not yet seen an antibiotic resolve the pain from either a reversible or an irreversible pulpitis. But You know, that's what we give our patients when we don't have the answer to their pain, or we don't have time to treat them. We give them some pills and we make an appointment to see them in 2 or 3 days' time, and they go through some murder before they get back to see us. It's prophylactic dentistry, it's overprescribing, and it's very easy to get yourself into some difficulty if you prescribe an antibiotic when it's not clinically necessary and the patient has a reaction. It won't be, oh, well, we didn't know the patient wasn't allergic to the antibiotic. It will be the case that the patient's lawyer will say, okay, well, was there any clinical indication to use the antibiotic in the first place? And that's what creates some discomfort for us further down the line, when really all we were doing was practicing defensive dentistry to try and protect ourselves from that very thing materializing. So then when we do get the complaint, we don't necessarily recognize it and deal with it professionally. You know, it probably is not a good idea to say to a patient, I've not done anything wrong and it's best if we see each other in court. That's not really the best thing to say to a patient when they're saying they're unhappy with the treatment or that you've been negligent and they want compensation. It's important to engage your brain and apologize. And apology is not an admission of guilt. It's just an expression of regret that this wasn't the outcome I or we had planned. And even if you say you've done something wrong, it's up to the patient actually to prove that you have. So there's too much fear around saying sorry that people don't do it when it's really needed. When you get a complaint, you need time to investigate. So it's important that you tell your patient, look, I'm really sorry about this. Give me some time to think about it. Give me some time to investigate what I think went wrong. And then contact your indemnity organisation, contact Dental Protection, and we will tell you what you need to say to the patient. We'll give you a strategy for solving the problem that the patient is complaining about. And it's at this point that my computer goes into a complete meltdown, and that's because there's a poll question on my screen. So that must be what's delaying everything. So let's see if once that's out of the way, I can move to the next slide. So let's talk about challenging patients in the last section here. And it's too easy to see the patient who complains as being difficult. A lot of the complaints we see are genuine and they're based on genuine concerns. And until you fully investigate, you cannot be sure that the complaint is vexatious and it's not justified. So please don't fall into the trap of immediately labeling people who complain as troublemakers and difficult patients, because your defensive reaction will be to eliminate the patient and the family from your practice, which is probably not a good idea when the kids have done nothing wrong and it's got nothing to do with them, nor has it got anything to do with the wife. It's an extreme reaction to say to patients that the professional relationship is completely broken down because you have complained. A complaint is an opportunity for you to identify something that may have gone wrong, and it's also an opportunity for you to right the wrong. But the danger is that we become all defensive and we eliminate the patient from our practice, and we all stick together, we all stand together and we say, well, I'm not prepared to see you and none of my other colleagues are prepared to see you in the practice because we don't believe your complaint is genuine. And all it needs sometimes to resolve a complaint where you're unable to see the patient or the patient's unable to let you see them is for another colleague, a fresh pair of eyes, to have a look at the patient, listen to their concerns, and to maybe provide some simple treatment that solves the problem. And taking that sort of approach rather than a more adversarial approach tends to reduce the number of complaints that go up formal channels and that are escalated to the HPCSA. And then finally, the last word tonight on defensive dentistry is defensive record keeping. And it's very easy for us to spot the record that has been rewritten after the dentist identifies or sees the complaint and realizes that the records are slightly short of the information that they might require. And there is almost a temptation to add more detail to the record. You can do it, providing you date it correctly and that the entry that you make is very clear that it is made subsequent to receiving the complaint. From my experience, it's very easy to spot the records that have been rewritten now that you know what the patient is actually complaining about, because the record seems to refer to those issues specifically when they weren't known at the time the record would normally be written. So what are the consequences if there is an attempt to rewrite history? Well, it actually invalidates the complaint and completely undermines your integrity and your defense. So as your indemnifier, I would very much prefer to see nothing in the records apart from ICD-10 codes, if it was that, or a rewritten record presented as the original when it's very clear that history has been rewritten. So even if your records are poor, send them to us when we ask them. Don't try and rewrite history, because it doesn't make our job any easier. In fact, it makes it a lot more problematic. So that brings me to the end of the presentation. And I'm very much aware that President Ramaphosa is making an announcement tonight that may be around another surge in COVID. So I agreed with Sudhir that we would have some time for questions at the end. And if we weren't able to pick up some of those questions, we would collate them and we would reply to the individual who had asked the question. So I'm going to stop sharing the presentation, Sudhir, and see where we are with questions, and if there's anything that you guys want to ask me about defensive dentistry. It's not an easy subject to talk about, and there is a fine line between defensive behaviour and unethical behaviour. So I'll leave it there, and thank you for your attention.
Thank you, Alasdair, for another enlightening webinar. Dr. Ramdo, do we have any questions for Alasdair tonight?
Yes, we do. We have a few questions that come in from some colleagues. So the first question is, I have spoken to many dentists and we have all experienced a drastic change where patients are most likely to sue or threaten legal proceedings against the dentist. As a result, most of us are wondering why.
Okay, so, I mean, I have to say I've never seen so many requests for assistance coming through from our South African members. And it's all seems to be happening in 2021. If I look at what we're being asked to assist with, I'm not seeing frivolous complaints. I'm seeing very genuine complaints from patients who feel that that they've not received the service they were expecting from their dentist. And I think a lot of this is to do with the financial situation in your country, and that more and more patients are making co-payments. It's not that the medical aids are paying for the treatment and they're not seeing money leaving their pockets. There are co-payments, and I think that when money's tight, people are less inclined to let dissatisfaction go and go somewhere else where they have to pay again for the treatment. So I am seeing a lot more complaints. I don't think it's because the way we practice dentistry is any different. It could be related to issues around PPE charges. We've seen one or two complaints about that, but generally they're the same sorts of complaints we've seen over the years, but there's just more of them.
Okay, another question that's come through is, what would you do if the patient is already seated in the chair, has an intraoral examination done, a pan taken to address her problems, asks for a denture to be made to cover incomplete implants, and then only tells you that she does not want to go back to her dentist because she cannot afford the rest of treatment? Is this a supersession? The patient is upset and demands not to be charged for the consultation and the radiograph.
It's a huge problem, isn't it? Just sort of unraveling all of the issues there. So, you know, if that patient walks in with that clinical story and there's obviously some work in their mouth that's not been restored properly, and there's obviously a reason for it. So there's alarm bells ringing, isn't there, when the patient first comes in. I mean, I think what you've got to say to the patient before you go any further is you need to speak to the dentist who supplied the implants that are unrestored and is involved in the treatment. And then it's about whether the patient allows you that permission, because this is where this ethical rule of supersession and contacting the patient is at odds. There's a tension with that, and the information that you're going to seek actually belongs to the patient. So the patient controls whether you can ask for that information and whether the other dentist can release that information. And that trumps the ethical rule of talking to the other dentist. If the patient says, I don't want you talking to the other dentist about my treatment, you can't do it. So, you know, so the problems are growing there, and then the patient makes some unreasonable demands on you, and you've got to make, you reach the point where you've got to make the decision about whether you are the right dentist for that patient, because there are enough warning signs there that says maybe you're not going to be the right dentist for that patient, and maybe you're just going to add to their list of dentists they're unhappy with. So I think nobody likes to turn away business, but if you get a gut feeling that this is not feeling right, then you do a U-turn and you say, look, I can't proceed here if you won't allow me to speak to my other dentist, to your other dentist. And, you know, without all of that information, without understanding, and without you being able to afford the treatment I'm proposing, I don't think I'm the dentist for you. So I think it's about identifying the risky patients. Some of us are not good at identifying them. Sometimes it's very difficult to identify the troublemakers, but you can usually tell initially by the fact that they've left somebody else in the middle of a complex treatment plan, and there's generally a negative reason for that. It's generally not for good things, so you need to be on guard.
Okay, can the POPI Act work for the practitioner as well? A complainant on the internet could be or is disclosing your information without consent. A double-edged sword for us all.
Unfortunately not, because the patient's processing their own information. So POPI says that you can process information about the patient for the purposes you've collected it for, which are to make records about their treatment and to have their telephone number and their email address. And that's it. Okay, those are the purposes the patient gives you permission to collect their data. Okay, a patient who discloses information about you, I mean, what confidential information is the patient going to have about you? It's all about their treatment. There's nothing that the patient's going to disclose that's confidential information. So I can't see how the POPI Act works for the practitioner. The whole idea of the POPI Act is to provide protection to the data owner.
Okay, another question that's come in is, how would you handle a situation where a female patient knocks on the front door when all other staff have left? She would like you to look at a tooth that has been discolored. Would you entertain this last patient? So I think the question's more about whether you would see this patient alone without your staff present.
It's the chaperone question, isn't it? I mean, if the patient's not got anybody with them, I mean, you could do that if the patient had somebody with them. But if the patient's not got somebody with them and the practice is essentially closed, it's not normal working hours, then it would be, as innocent as the request is, it would be ill-advised to agree to see the patient. I think what you would be better saying is that you can't carry out a proper assessment without the proper equipment, with the surgery properly prepared from infection control protocols, and you'll find excuses to encourage the patient to book a proper appointment and not slip them into the surgery and see them there and then without a chaperone. 99 times out of 100, there's never a problem, and the patients don't realise the risk that we see as dentists. But you just don't want to be that 1% where there's allegations that he took it or she took advantage of the situation, and there's a report to the police or to the HPCSA of sexually motivated behaviour. It's just not worth it nowadays.
Is video or audio recording during clinical treatment allowed as part of your record?
I mean, the answer to this question is, why do you need video? I would say audio, sound is allowable, but the problem is, and we keep talking about this, I think this is a great idea, but the problem is, one, you've got to get the patient's permission to record it, okay? And then secondly, because it's a recording, it becomes part of the patient's treatment record, and it has to be retained and it has to be accessible for the minimum number of years, whether it's 6 or 10. I can't actually remember the specific time frame for that, but that's the problem, is the recording becomes part of that patient's record, and you've got to be able to store it with the record. So there will be digital solutions. There are clever people out there who will be designing software products for the dental professions, and I think that, you know, if that's what you guys are good at, somebody in there can develop a digital solution that we can all benefit from, that's easily storable in a cloud and is part of the patient's record. But I'm saying, if it's just the conversation that matters, which we think it is, then you don't need video. And then once you've got video cameras, then you've got to get your staff's permission as well. And then there's the question of, okay, what are you going to do with the images? And we're back to, they could be used improperly, because we've seen that. We've seen cameras innocently positioned, and for somebody to make an allegation that they were pointing at the wrong part of the patient. So I don't see the point of having video. I see great benefits in recording conversations, providing they can be stored safely as part of the treatment record, because that's what they are.
Okay. Does the POPI Act not prevent us from getting treatment info from another treating clinician?
So let's just talk about basics here. The information that you write in the treatment record belongs to the patient. That's the patient's information. The card that you write it on, or the software that you save it on or write it to, is your property, okay? So the property that the information that another dentist retains for a patient belongs to the patient. So you still need to get the patient's permission to get hold of that information. So the patient needs to go to the other dentist and say, I give you permission to release the information to Dr. Rotherham. So POPI doesn't, the consent you get from the patient is for processing the data that you store in relation to their treatment, your practice, but it doesn't give you the right of access to anybody else's data.
Okay, another question that's come in is framed like this. Sometimes a patient's financial position makes it easier for them to prepay for planned treatment. This can either be a single deposit or monthly advance payments.
Is that a statement or a question?
Yeah, it looks more like a statement. So I think they want to figure out, if a patient pays in advance for treatment, what's the legality around that?
So I'm not sure that I know what we're asking. So prepay. So can you prepay for planned treatment? I mean, there's an ethical rule that says that you cannot charge for services not personally rendered, which could apply to the situation where asking the patient to pay up front for their treatment that's actually not being provided. So there's potentially somebody could misinterpret the rules there, but hang on a minute. I mean, this is simple stuff. So if a patient wants to make a deposit up front for planned treatment or pay monthly in advance, and particularly if it relates to laboratory items, then I don't see what the problem is. But there may be a problem that Pankaj Govan can explain to us if he's on the call or not. But I don't see a problem with that. But there is that ethical rule about charging for patients for services not already rendered. But you're not charging the patient's actually paying you up front. So I'm not convinced I see a problem with that. And if there was a problem with that, I don't see how you could get into any trouble.
Okay, because the follow-up question to that was the patient has an understanding that if treatment does not go ahead, they will receive a full refund. Yeah,
absolutely. I mean, I think that's part of the trust in the relationship. If the patient decides not to go ahead, then you can't keep the money. You got to give them it back.
So there's another question that's come in. It's more about clarity. So if a patient comes to you from another dentist, do you need the patient's permission before contacting the first practitioner to discuss the case?
The rules on supersession would suggest that you don't need the patient's permission, but I think that you do. I think that it would be sensible to say to the patient, look, I need to contact the first dentist. Are you happy with me to do that? If you contact the first dentist without the patient's permission and that dentist then gives you clinical information, then it's them that have breached the patient's duty, breached their duty of confidentiality to the patient. So you're not going to get in any particular trouble unless you discuss what you've seen with the previous treating dentist. So again, to be safe, nowadays, consent is everything. It makes sense to just say to the patient, look, to make sense of the treatment plan, we need to know what happened the last time you had treatment. Are you happy with me getting some information from your previous dentist? And the patient says, no, I'm not happy about this at all. I said, well, this makes life very, very difficult for us. Would you like to reconsider your decision?
Okay, another question has come in. Can you please clarify, when does dental protection provide support? In your talk, you mentioned that members should contact you once a problem or a patient makes it known that they will be taking the matter further. Previously, the understanding was that only once a complaint has been lodged at HPCSA, then will dental protection provide support. Please clarify this, as it may be beneficial for members to have the support earlier in the complaint process to possibly prevent it from getting to the HPCSA.
Okay,
perhaps this should be better highlighted as a function of the dental mediator.
This is really unfortunate because we're very keen to be informed right at the start when patients are unhappy, because generally we can give the right advice and support to our members in South Africa to help them manage and respond appropriately to the complaint. So the minute you receive a letter from a patient and you're a member of Dental Protection, then please contact us, because we're only too happy to help with those. And I've never seen any literature or written material that says you can only contact us when there's a complaint to the HPCSA. So that's completely different to what the service we offer our members. And if you look at the member benefits on our website, you'll see very clearly there that we're happy to assist with complaints. So the second question is about the dental mediator. The SADA dental mediator is there primarily as a function to assist patients who are unhappy with their treatment. So the patient will go to the mediator and say, look, I got a problem with my dentist. I've said I'm not happy about this, and the dentist has refused to do anything about it. Can you help me with it? And then the mediator will contact the dentist and say, I've got one of your patients here. There's a problem. Let me help you find a solution. And that's how the mediation works. So the dentist generally should come to their indemnifier. Occasionally, I know that they do go to the mediator, but if they go to the mediator and talk to the mediator about the patient's treatment without the patient's consent, again, it amounts to a breach of confidentiality and the processing of that data against the POPI principles. So we would much rather prefer if if dentists contacted us about with complaints. If they anonymize the patient's identity, then that helps reduce any of the processing issues that we see. But if you contact the mediator and say that you've got a problem with Mrs. So-and-so, then the mediator can only contact Mrs. So-and-so if she's given permission for him to do so. So it's more likely that if the mediation service works when it's initiated by the patient, and then there are no issues around confidentiality. But when it's initiated by the dentist, then we've got potential breaches of confidentiality that we have to negotiate.
Okay. There's a question about, do I have to inform a colleague if a patient consults me for a second opinion?
The ethical rules are very clear, is that you must never interfere with the patient's right to obtain a second opinion. So, the HPCSA expects us not to put any barriers in place. Do you have to inform a colleague if a patient consults me for a second opinion? Well, the answer is that you're going to have a conversation with the patient, and it may be that you can only give the patient that second opinion if you have the information from the first treating dentist. So there's going to be a conversation between the patient and you about what the first dentist did, and that's why they're coming to you for a second opinion. They're not quite happy with what's been proposed, and it may be that you can't discuss the treatment sensibly unless you know what's been proposed, and patients are not particularly good storytellers. So it's part of the conversation with the patient. Again, down to consent. It's down to saying to the patient, look, it's going to really help me if I can talk to your own dentist. Are you happy for me to contact him or her?
Okay. There's a follow-up question about what about after hours or emergency consults? How are we covered for this if we are often alone in the surgery?
I mean, really,
it's a bit of the follow-up to the previous question.
It's kind of the chaperone issue. I mean, I think what you're going to have to say to your patients, if you are on your own, I think it's really sensible to ask the patient to bring somebody with them. I mean, that's the get out of jail free card here if you don't have a member of staff that comes with you. But it's a real worry that, we do get called out. We do have to go and see some of our patients at times when the surgery is not open. We do that as a service to our patients. Our staff are less inclined to come out with us and see those patients, and they're less inclined to be sitting around and not get paid for it as well, waiting for the call that might never come. So it's a real challenge, but the way around about this problem is that you get the patient to bring somebody with them. Otherwise, there is a risk, but hopefully it won't materialize in the circumstances where a patient's got a genuine emergency and you're doing what you can. I mean, if it's just clearly not safe to do the emergency treatment and the patient without somebody being there, then you've got to find a solution to the problem.
Okay. In a medical legal scenario, how much of emphasis is placed on unprofessional advice given to the patient by nurses or admin staff?
It's by Dr. Kassoon, isn't it? Okay. Good evening, Arniel. In a medical legal, so how much of an emphasis placed on unprofessional utterances, advice given to patients by nurses? Look, all nurses are registered with the HPCSA, so If a patient is unhappy with something they've said, then they face the same disciplinary process. If you believe that the conduct of a registered member of staff falls well short of what's expected, and there's a breach of the ethical rules, then you're within your rights to start a disciplinary within the practice, and also report the individual to the HPCSA, to their professional board, for consideration of the unprofessional conduct. So there are ways. How do you know that your staff have been unprofessional? Well, maybe somebody's going to tell you a story. It's part of the disciplinary process within the practice. It's got to be investigated. There's got to be a meeting, and you need the HR consultants in there to help you do that. So for members of staff who are not registered with the HPCSA, then it's a problem. It's a training issue. It's a leadership issue. It's a disciplinary issue. It's something that we don't want happening in our practices, but I can't give any specific advice of what the outcome is likely to be, but there are a number of options open to you as the employer.
Okay, I'm going to hand over to Dr. Rathiram for the rest of the questions.
Thank you, Dr. Ramdo. I know we've passed the 8 o'clock mark, but this webinar has been so energetic, and our delegates have been so fantastic that the questions are just flowing through. So we're just going to allow a few more questions, Alasdair. I believe while our president is still setting up his webinar platform for all of us in South Africa tonight. There's a question here. Why can patients admit audio recordings without our knowledge for legal proceedings, but we as practitioners have to disclose and get permission from the patient to record conversations?
Hi, Elsie. Why can patients admit audio recordings without our knowledge for legal proceedings? Because they can. But, you know, as a practitioner, you've got to obtain the permission of the patient to make a recording of the consultation. That's just the way life is for us as dentists and medical practitioners. There are two rules. There's one for our patients and there's one for us. A lot of dentists are unhappy about the fact that people walk into surgeries with their phones and record consultations without anyone even knowing. What's the admissibility of those audio recordings? Well, look, you know, did you say to the dentist you were going to record it? No. Okay, so what was the purpose of making the recording? Well, I was trying to catch the dentist out. You know, is that fair? I'm not sure, and all of those things are weighted as far as the quality of the evidence is concerned when it gets into legal proceedings. So I'm not necessarily worried, but I know that practitioners are, because I know it's easy to drop your guard and say things that you're least expecting. And it's a bit like the mystery shopper scenario where somebody comes in, asks you to do something that's obviously unethical, and they're recording you. It's a form of entrapment, and the courts don't like it. But it's something that we live with. Why have you got to get the patient's permission? Because you have to, because it's part of what we do. It's part of patients' permission to process their data, their information, and we are required by law to have their consent to do so.
Another question, what would you do if you observe a colleague who continually fraudulently abuses medical aid schemes from information received from patients that visit your rooms?
I mean, that's interesting, because it says if you observe, so you're actually seeing this individual who is obviously making fraudulent claims for medical aid. So it may be that they're claiming for treatment that hasn't been carried out, or in some cases, and I've seen a number of examples of this, where the dentist is claimed for some permanent restorations, but the patient's left with temporary restorations and saving the cost of the definitive restoration. So what do you do if you observe a colleague? You know, we've moved into into an environment where people are encouraged to blow the whistle on fraudulent and unprofessional conduct and behaviours that either risk the patient or puts the profession at risk reputationally. And I think what you've got to do is it's really hard now, but you've got to challenge them with the evidence and say, you know, this is what I've seen. Here's the evidence. What do you say about it? And you know, most people who are taking a chance and know they're doing something wrong will probably put their hands up and say, yeah, actually, this is not good, and will stop the behaviour. But you know, if they're completely immune, that their moral and ethical compass is pointing in a completely different direction from everybody else in the profession, then you must report it to the HPCSA. If it's serious enough and there's patients being harmed by it, then you report it. But you know, I'm not necessarily seeing patients harmed if a dentist is claiming for something that they've not done, compared with a dentist who's telling patients your treatment's complete and they're leaving with thinking they've got the definitive bridge or crown, and it's just a temporary or it's an acrylic thing that it's not going to last and protect them. So it's a really difficult conversation. But it's something that has to happen. If you do report somebody like that to the HPCSA, you do not have to prove your case. It's up to the HPCSA to investigate and up to their pro forma complainant to prosecute the case against the registrant. So you're not required to justify the fact that you're referring the case to the HPCSA. So you can feel that you don't have the burden of proving what you think. That's down to the HPCSA. But I think there is guidance about reporting. There is HPCSA guidance around reporting colleagues who you have concerns about.
Thanks for that, Alasdair. Another question here is, do I need a patient's consent to send x-rays and clinical findings to a medical aid for motivation for treatment, such as authorization for a crown?
Absolutely. Absolutely. I mean, the medical aids will say, oh, no, the patient's already agreed. Here's the form they signed with us. But that's not an agreement with you. That's an agreement with the medical scheme to process their data. That doesn't allow you to disclose the information without the patient's consent. So if you've got a medical aid asking you for motivation for treatment, then you've got to say to the patient, I'm being asked to disclose this information. Are you happy for me to do so? It's nothing more than that. It's not a big letter and a signature or anything like that, but it's important that you get consent from the patient and then make a note of that the patient was spoken to and they gave the permission and they understood what information was being disclosed.
Here we have, it's more of a comment than a question, but I think this is something to note. I realize while I am busy with procedures, parents, spouses, and so forth take videos of my procedures, which is rather very difficult. And I think with the new social media world that we live in, Alasdair, this has become very much a reality. Any advice you can give on that?
I mean, it is reality TV, isn't it? I mean, you know, listen, I'm too old to get excited about all the benefits of social media and sharing information. But the only thing you can do is say is that, you know, we have a policy here that switch your phones off when you come into the surgery. And the reason why we have that policy is because, you know, this is doing dentistry requires a lot of concentration, and it could be something simple, a distraction like the phone that leads to an error or mistake or to something happening here. So we just have a practice policy that we say, please, a polite no phones in the treatment room policy, and you expect your patients to comply with that.
Absolutely. Alasdair, just the last two questions for tonight. Does DPL communicate only via email, or is it possible to chat to an advisor telephonically?
So most of our communication takes place by email. I mean, I do a lot more Zoom calls with members now on open cases. So the pandemic has actually improved the way that we communicate. I mean, you just look at how many people are still in this webinar tonight. There's 492 people in the room, in the digital room tonight, and you wouldn't even get that at SADA Congress. So the ability to reach out to large numbers of members is huge. Can you speak to a dentist? The problem is that we don't have a dedicated telephone line that has advisors at the end that understand what's happening in South Africa and South African dentistry. And you can speak to us. If you go to our website, there are a number of telephone numbers that you can dial that will actually take you through to our advice line, but it is manned by people who have very little knowledge of the South African market. This will all change because we have our new administrative function based in Pretoria, and we're going to develop a reporting line with them. Once we've got the reporting line up and running, then we're going to extend it to a medical legal and a dental legal advice line. So that service is coming. If you really need to speak to us urgently, then try and get a message to me via Ruth at SADA. And if she contacts me and say, I've got a dentist that needs to speak to you urgently, then I'll try and ring you back, or I'll send you an email saying, when's it convenient to speak? So we can do that. You just got to remember that sometimes I'm not necessarily in the office. I'm the only one in the UK at the moment who has complete visibility of what goes on in South Africa in terms of knowledge of the systems. There are other dentists who handle South African cases who have knowledge of South Africa, but maybe not be able to answer your specific question. And in an emergency, if you were really stuck, then you're a member of SADA, you can speak to Punkash straight away. And if you're really, really, really stuck, then you could speak to Dr. Barnard, who's the mediator, and he would help give you some advice in an emergency. But look, if somebody lets me know that you need a call with a telephone number, I can call you back pretty quickly. It's not a problem.
That's quite encouraging news, Alasdair, to hear that soon enough there will be a line available to the South African colleagues. Alasdair, the last question for tonight is, what do you do if you find another dentist is working on your patient in the middle of your treatment without telling you?
So if you find out, well, you're going to be very angry, aren't you? So what do you do? So it's almost like somebody's having an affair with somebody else here. I mean, it's not something that you want to find out, really, is it? So what do? You find out that somebody else is treating your patient. I think you've got to contact the patient and say, look, come on, what's going on here? And that's all you can do. I mean, the new dentist is, in a sense, is protected by the patient and the patient's permission to speak to them. But if you look at the supersession rules, it's very clear that the HPCSA don't agree with the fact that someone else can take over somebody else's patient without telling them. So there is still a risk. I think that rule is probably outdated, and I think that if the conduct of the new dentist was held against that rule, I think it could be easily challenged because it doesn't represent where we've gone with patient confidentiality. The pendulum swung in that the patient carries the key to all their secrets, and but you can always try and speak to the new dentist, and if he tells you anything, then it's his breach or her breach of confidentiality.
Alasdair, I have to take this one last question from Dr. Yash Naidu. I'm sure you know Dr. Yash Naidu pretty well, and he wants to know, and this is quite a burning question here, Alasdair, who is going to win the Euros?
Okay, so Dr. Naidu knows nothing about football. I mean, he wouldn't know which feet to put his football boots on. He's expecting me to say Scotland, but he already knows that I think Portugal are going to win the Euros. So that's my tip. And if it's not Portugal, I'm going to go for England.
Okay, on that note, Alasdair, I know tonight was a very difficult topic to discuss, but what I would like to ask of you for our younger colleagues, what would be your closing comments with regards to defensive dentistry?
Well, the funny thing is that I thought this was a webinar for young dentists, but I see people like Dr. Redlinghuis on the webinar, and I'm just wondering when he was last 25 years old. What would be my closing remarks or best piece of advice to young dentists? I think that if do never undertake a treatment that you're not competent to carry out. Okay, that's the first thing. Never be afraid to ask somebody else to help you, and never be afraid to arrange some coaching or mentoring from other colleagues, from practitioners, where you identify gaps in your clinical skills. I think that dentistry is a journey. I think you learn every year and you learn more every year. There's no fast track to experience. We're all capable of making mistakes. We're all capable of underestimating our competence as well. And I think we're all capable of agreeing to do things that we're probably not yet ready to do. So my advice to all of the dentists on the call tonight is recognize your limitations, identify where your weaknesses are and where you want to develop, and make sure you develop with the right people so that you can do things to the very best of your ability.
Thank you for that, Alasdair. In fact,
and there is one more piece of advice. And that piece of advice is, do not ask Dr. Naidu for a tip about football.
Certainly. In fact, Alasdair, when it comes to the point of a younger dentist, I always say young in age, but also young in heart. So we have a lot of young at heart dentists also attending tonight's webinar. And I cannot end the webinar tonight without saying greetings to Dr. Clement, all the way from the United States. Dr. Clement attends, I think, all the SADA webinars on the Zoom platform. And that's one of the advantages of having webinars in this array. So one of the good things we can see from the COVID experience. And Dr. Clement would like to tell us that it's amazing that the laws in the US are identical to those in South Africa, just like the rules of golf, Alasdair.
It is. I mean, absolutely. I mean, it's the same thing, the same ethical compass when you play golf is that you never cheat. And when you do, you stop playing golf. And it's a bit like that in dentistry. There's no room for cheaters. And, you know, we've got rules that everybody is expected to comply with, and they're there for a reason. They're there to protect us. They're there to protect the reputation of the profession, and they're there to protect the interests of your patients.
And with that, I can see we are 20 minutes into the president's speech, so I have to call this webinar to an end. I wish to thank you, Alasdair, for availing yourself tonight and for enlightening us further on the topics pertaining to dental protection. I'm sure colleagues have generated quite a bit of value from tonight's webinar. And I also like to thank the guys behind the scenes, Tsepo and Maralise, who works effortlessly ensuring that our webinars run so smoothly. And as you can hear, I'm also ready to close up for tonight to catch the president's speech. So thank you everyone for attending tonight. At the end of the webinar, there is a survey that will come up. Please fill the survey in, and everyone have a good and blessed evening, an enjoyable Youth Day tomorrow. Take care and good night, everyone.
Thank you, Alasdair. Good night.